Hello, everyone, and welcome to our webinar on high-yield leukocyte disorders with a particular focus on immunodeficiencies. My name is Moses Murdoch. I am an internal medicine resident. I'm also a senior USMLE tutor with Blueprint and Med School Tutors, and it is my pleasure to be giving you some high-yield information for your USMLE and complex examinations. A brief word about us before we get started. We are a group of med students, trainees at various levels, from residents to fellows, even some attendings who have had success in navigating the standardized exams that go along with medical training, who are passionate about medical education, who really like working with students, and we really love to teach. We predominantly do one-on-one online tutoring, but there are a variety of ways in which we can get involved, whether that be group settings or plugging in with the other services that Blueprint offers. I'm not going to spend a ton of time on this, but you'll notice at the bottom of the slides are social media handles, phone number, and an email address. If any of what I've just said speaks to you, please reach out. We would love to hear from you. We'd love to connect you with any services that we offer. And we'll have some information at the end of the webinar with some offers as well. But that's not why you're all here today, to go over leukocyte disorders. Now, there are many diseases that involve the immune system, whether it's autoimmune diseases, immunodeficiencies, there's malignant transformation of the immune system. We're going to focus mainly on immunodeficiencies. And the reason for that is because there's a lot of nitty-gritty detail. They're fairly rare disorders, but they're high yield, easy points if you know what the answer is, and can really be helpful on test day. As the slide shows, we won't really be covering malignant etiologies. And by that, I mean leukemias and lymphomas in any detail, because we've had another webinar on that already, and there's only so much we can cover in an hour. I do want to highlight that my hope is for this to be a very interactive webinar. You'll notice a message in the chat box thanking you and welcoming you to the webinar. Please, 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 along the way, I will be asking you questions. Go ahead and put your answer in the chat. You can send them just to me or to everyone, whatever your preference. But recall that active recall is really important for encoding long-term memories, and we're hoping to flex that muscle a little bit today. At the end of the webinar, we will have a live Q&A. If there's anything related to the topic we're covering today that is still an area of uncertainty for you, would be happy to answer any of those questions at that time. And with that, we'll go over some general tips for how to approach questions within the sort of immunodeficiencies and leukocyte disorders space, but some of these tips also apply to basically any vignette. You really want to use all of the information that is provided to you to help eliminate incorrect answers and get to that one best answer. There will be multimedia on your exam, whether it's a radiology image, a histology slide, whether it is a heart sound and auscultation. It can be really easy to freak out a little bit if you don't immediately know what's going on in those multimedia formats that are included in your questions. But recall that you have clues from the demographics of the patient to their signs and symptoms, lab abnormalities, physical exam findings that are described in the text. And you should incorporate all of that data to help you get to the right answer. If you're not totally sure what's going on in one piece of that complex data structure, you can still get to the right answer. The other thing to remember is that for the most part, the test writers are not out to trick you. They're not going to be picking something that only a radiology resident or fellow or a pathology resident would pick out. They're going to give you sort of bread and butter examples of the diseases that you're supposed to know as a medical student. And the last point I want to make is memorizing a bunch of facts is useful, no doubt about it, but it is even more useful to organize your knowledge into schemas and illness scripts. And by illness scripts, I mean the collection of signs, symptoms, and background information that make up the classic presentation for a disease, because this is the type of presentation that is likely to show up on your exam. So for example, if I described an older gentleman presenting with a couple hours of crushing substernal chest pain that radiates down the arm or to the jaw, associated with shortness of breath and some sweatiness, I think most people, even laypersons, would recognize that as a myocardial infarction. And so that's what I mean. That story I just told is the illness script for a heart attack. And you want to develop that sort of illness script for the many diseases that might show up on your examinations so that you can recognize the buzzwords, get to the diagnosis, and answer the basic science question that will then be asked of you. Drilling down now into the world of hematology, I'll offer sort of my framework for hematology writ large. Recall that the master cell of the bone marrow is the hematopoietic stem cell, and that stem cell differentiates over the course of several generations into all of the immune effector cells that are found in the peripheral blood and that reside in end organs. Now, of course, you have granulocytes, you have red blood cells, you have platelets, and white blood cells, and granulocytes being a subset of white blood cells. It's really important when thinking about the immune system to divide it up into the innate and the adaptive immune system. Recall that the innate immune system is very fast, but it lacks memory. The way it works is it recognizes sort of the general shapes or patterns or surface molecules that occur within classes of bugs, right? So it's either LPS, lipopolysaccharide, or the various ligands of toll-like receptors. On the other hand, the adaptive immune system is a little bit slower. It does have memory, and it recognizes more specific patterns that are on the surface of microbes and viruses, such that if you're re-exposed to that particular pathogen, you can respond quickly and in a more specific manner. We won't spend time really thinking too much about red blood cells or platelets, or as I mentioned, the malignant hematology, but that's a big framework of the types of problems that come up in hematology. Occasionally, we'll be seeing blood smears in this webinar, and I just wanted to point out a normal peripheral blood smear. You'll notice that the predominant cell are red blood cells. I won't spend too much describing them because there's a whole webinar on that as well. You'll notice that there are a number of white blood cells here, and again, too much or dysfunctional or abnormal, dysplastic in some way. Here we're seeing a couple of leukocytes, and I'll just use some arrows to point out the different cellular elements. In the red arrow is pointing to the red blood cell, the white arrow is pointing to a neutrophil, and it's tough to see at this magnification, but the blue sort of cyan arrow is pointing to a platelet. Okay, so from here on out, we're going to go through a number of classical vignettes or classic images, and this is where it starts to get interactive. So I would love for you all to put in the chat, what do you see in this blood smear? What looks abnormal, different from the slide that I just showed? Go ahead and put it in the chat. And I'll give you a clue. We're talking about white blood cells here. So there's something about it, about looking at that subset of cells that is abnormal. I love the participation here. The framework that I have for this is, are the number of cells abnormal and do they look abnormal, right? And if we're focusing on the white cells, we see that there are increased number of white blood cells And this is an example of what you might see on a smear in a leukemoid reaction. So sounds fancy. Essentially what it means is the immune system is responding usually to a very severe infection, although sometimes you can see it in a malignancy, and you have a granulocytosis. Sometimes it's referred to as a left shift. In other words, shifted, the spectrum of cellular elements in the peripheral blood is shifted to granulocytes and early band form. So excellent, excellent in the chat. The big differential diagnosis. Let's say you have a patient coming in and their white count is 60,000, right? 60,000 is markedly abnormal. I mean, it is 5 to 7 times higher than the upper limit of normal in most laboratories. And one of the key differential diagnoses is to distinguish it from CML, chronic myeloid leukemia. Again, in the chat, what marker, what lab is high in a Leukemoid reaction that is low in CML? Awesome, y'all are too good. It is the LAP, the leukocyte alkaline phosphatase. And conversely, what is present in CML from a genetic marker standpoint that is absent in a Leukemoid reaction? What is the classic translocation in CML? Perfect. So the presence of a high LAP and the absence of a BCR-able transcript is what helps you differentiate the Leukemoid reaction from CML. To comment a little bit on some of the other answers, you can see some stacking of chips appearance to the red blood cells, otherwise known as rouleau formation. Classically, that's associated with multiple myeloma, where the excess proteins of immunoglobulins that are being pumped out by the plasma cells leads to electrostatic interactions between the cells, and the red blood cells tend to stick to each other. However, you would not necessarily expect a granulocytosis to this degree in multiple myeloma, right? And the other point is that although we have cells that have differences in their lobation, in other words, how many lobes they have, most of the cells on the slide here are actually granulocytes or precursors to granulocytes. Okay, I'm also seeing what might look like a monocyte here as well, which again is a granulocyte. Awesome. Let's keep it going. And again, feel free to throw questions in the chat and keep up the participation. So here's the other end of the spectrum. We have another peripheral blood smear. What do you all notice either about the number or the visual characteristics of the white blood cells here? And I already see one correct answer in the chat. Y'all are too good. Great observation in terms of microcytosis. A little bit tough to see at this magnification. It certainly could have some microcytosis, but the focus on the white cells, what we're really seeing here is neutropenia and agranulocytosis. So first off, a definition. Neutropenia is less than an ANC, an absolute neutrophil count of 1,500. And there's sort of 3 tiers to neutropenia. Mild is between 1,500 and 1,000. Moderate is between 1,000 and 500. Severe is less than 500. And agranulocytosis is less than 200. And as you might imagine, if you don't have neutrophils, you're losing one of the most important components of the innate immune system, and you're predisposed to infections, particularly with bacterial organisms. There are many reasons why folks have neutropenia, right? One of which is chemotherapy. I want to be an oncologist, so this is very relevant to me. And many chemotherapies can lead to neutropenia and agranulocytosis, and patients often get support with GM-CSF or GCSF to help boost their neutrophil count. Very rarely you'll have congenital causes of neutropenia. And there are several medications that are just classic specifically for causing agranulocytosis. And that's what I want to test you all on now. So which antipsychotic is classically associated with agranulocytosis? Awesome. So clozapine, classic cause of neutropenia. Now, what about an anti-epileptic? Clue, it also starts with a C. An anti-epileptic that can lead to agranulocytosis. Yep, carbamazepine, perfect. What about an antiviral that can suppress counts? An antiviral medication. Great, so it's a sister drug to acyclovir that treats the same types of organisms. It's actually ganciclovir, exactly. So ganciclovir can lead to neutropenia and agranulocytosis. And then there's a couple of thyroid medications that can lead to agranulocytosis. What thyroid medications? I'm already seeing one correct. Yep, exactly. So propylthiouracil and methimazole can cause agranulocytosis. Just to comment, myelofibrosis, the classic finding that you'll see, and this is particular in the peripheral smear at least, will be dacrocytes. And dacrocytes are those teardrop-shaped cells that result from the red blood cells being deformed as they exit a fibrosed marrow. And in the marrow, you can actually stain for fibrosis, for instance, with reticulin stain, and that may show some the increased amount of fibrosis as well as dysplastic features. And there's obviously a risk in myelofibrosis to progress to an acute myeloid leukemia, one of the feared complications of primary myelofibrosis. And just because I can't help myself, the JAK2 V617F is the mutation you're looking for with myelofibrosis. Okay, let's keep it moving. And thank you all for adding other medications that, that can lead to neutropenia in the chat. That's super helpful. Okay, so here we have both an image, that's a test, and a vignette. So here we have a 9-month-old boy with recurrent bacterial and enteroviral infections. He has no palpable or visualizable lymph nodes. He doesn't have tonsils. And we have flow cytometry findings that are shown on the right. And just to orient you all, remember that flow cytometry is where you use fluorescently labeled antibodies that you can then use to incubate with cells and mark cell surface molecules and define subpopulations based on those those cellular membrane bound molecules. The top panel shows a control cell where, and again, each axis is labeled. If it's a little small, I'll just say it out loud. The x-axis is CD3, which is a marker for T cells, and the y-axis is CD19. I'm not going to tell you exactly what CD19 is a marker for, because that would give it away. And you see that the controls don't have that population that is CD3 negative, CD19 positive. Okay, a lot of information there. What's a possible diagnosis that could lead to this finding? And the point here is that from here on out, we're going to be talking about immunodeficiencies, mostly genetic immunodeficiencies. Okay, so we have a vote for SCID. SCID. Let's talk through that. Remember that SCID stands for severe combined, and the word combined is really important. Severe combined immunodeficiency, where you have absence of both T cells and B cells. And you'll notice that CD3 is a marker for T cells. The patients still have T cells. In other words, there are cells that stain positive for CD3. Therefore, you think that they're T cells. However, it's the non-T cells, and CD19 is a marker for B cells, where the control does have B cells. The patients do not have B cells. So now the question that you're answering is, What immunodeficiency is characterized by the absence of B cells in boys and predisposes to recurrent infection? Is there an immunodeficiency that makes you think that pattern makes you think of? And I think someone in the chat got it. This is Bruton's agammaglobulinemia. Keep in mind, and this is a big help for you all, for the rest of the webinar, we're going to be talking about immunodeficiency. So we're not really going to be talking about cancers. Burkitt, for instance, is a B-cell lymphoma, right? And there you would expect a really large lymph node. It's an aggressive lymphoma and associated with MYC alterations. The 814. Okay, so perfect. Bruton's. What gene is mutated in Bruton's agammaglobulinemia? Perfect. I've got two answers related here. So the gene absolutely is BTK, Bruton's tyrosine kinase. It is X-linked, hence why it tends to affect boys. What would you see in terms of lab values? And this is obvious, it's in the name. If it's agammaglobulinemia, what would you see on, absent B cells, right? And you would see low immunoglobulins because you don't have B cells. Perfect. And what would you not give? What kind of vaccine would you not give to these patients? Bingo. So you don't give live vaccines, right? You could probably pursue a whole PhD studying the signaling pathway of BTK, but for the purposes of exams, what's on the slide is generally what you need to know. The clinical presentation along with these basic science facts. All right, let's keep it moving with the next vignette. And this is one that doesn't have really an image associated with it, but it's a young adult, so notice that it's a different population now, that has celiac disease, who has eczema, and this is the big clue. And of all the times I've seen this question come up, this is one of the key little buzzwords. It's someone that has a severe allergic reaction to a packed red blood cell transfusion, and it's in a young adult. Yep. So I see a correct answer in the chat already. This is selective IgA deficiency. So key to remember the association with celiacs and the allergic reactions to packed red cells. And on the slide there, you just see the different configurations of the immunoglobulins in the different classes. Okay. Next question. We have a young child with recurrent viral infections, has hypocalcemia, has a cardiac abnormality, and has the chest X-ray at right. What disease do you all think this patient has? And my goodness, y'all are too fast for me, too good. Yes. So this is DiGeorge syndrome. Let's walk through the facts that you need to know. So what is the genetics? I see one correct answer that came just to the host and panelist. What abnormality will we see? So deletion of 22q11. Deletion of 22q11 and obviously the associated genes on there is what you'll likely to be tested on. And some folks are already getting ahead of me, but what embryological defect is at the root of the DiGeorge syndrome? And I see a vote for third pharyngeal pouch. I see a vote for third and fourth pharyngeal pouch. Yeah, so the third, fourth pharyngeal pouches don't develop, and that's the embryological correlate. We sort of already mentioned the labs where you have a low calcium, and that gives you the finding of tetany. You see a low PTH, and you can remember that because PTH controls the calcium. If you have a low PTH, you're likely to have a low calcium, and it's due to the fact that the third and fourth laryngeal pouches also control some of the endocrinological cells that end up producing PTH. And the reason you have an immunodeficiency is because it impacts your T cells. Okay. Can you all in the chat name some of the congenital cardiac disorders that are classically associated with DiGeorge syndrome? Yep, so the thymus is affected. Tetralogy of Fallot, that's absolutely correct. There's one other one that's a classic association here, that if you see it, you should think DiGeorge in the appropriate clinical context. Truncus, yes, perfect. So tetralogy of Fallot and truncus arteriosus. On the last slide, you saw sort of a front-on view of the chest. Here we have a lateral view. And what you're noticing is that there's the absence of a thymic shadow, right? So normally, and this is a normal child, the thymus is prominent on the chest X-ray. And obviously, if you have a problem with the thymus, a problem with T cells, then you are likely to see a narrowing of that where the thymus would be, and that gives you a clue that the thymus is missing, involuted, and should clue you into DiGeorge syndrome. Note that an absence of a thymic shadow is not absolutely unique to DiGeorge's, because there's other diseases, other immunodeficiencies even, that can present with an absent thymic shadow. But if you also see the hypocalcemia and you see 22q11, or you see cardiac abnormalities like those listed on the slide, then you should really be thinking about DiGeorge syndrome. Okay. Y'all are doing an excellent, excellent job. Here's another classic disease. You have a young child, and they get recurrent infections, and you notice that they develop abscesses. But there's something weird about the abscesses because they don't have the other classic signs of abscesses. There's no redness, there's no warmth. Speaking of skin stuff, you also notice that they have eczema, they have easy bone fractures, and they have the facies at right. And what you're seeing here are some problems with retained teeth. What immunodeficiency? Got a couple of votes here. I love it. There's a debate going on. This is excellent. So the answer in this case is Hyper-IgE syndrome. It's also known as Job syndrome. What were the clues? And by the way, folks, we'll have slides on some of these other immunodeficiencies so that you can compare and contrast. The key thing here is the combination of the abnormal facies and some of the skin findings. So the cold abscess is really critical here, and can really clue you in, right? The bony fractures, the teeth, the retained teeth issues, that's also very classic for Hyper-IgE. And so now, once you've made the diagnosis based on the vignette and maybe a clinical image, the question that's going to be asked is probably one of these basic science questions. So let's go through those together. What gene is implicated in Hyper-IgE syndrome? We got some geneticists in the crowd. I love it. Yes. So STAT3 is the gene. And what about the inheritance? Is it X-linked? Is it autosomal dominant? Is it autosomal recessive? So it's autosomal dominant. And then what is the cellular defect? And by that, let me maybe give you a more specific question. What subset of T cells is implicated in Hyper-IgE syndrome? Yep, Th17. It's one of the lesser talked about T cells. Recall that the big division that we think about are, CD4 versus CD8. The CD8s are the cytotoxic, the CD4 are the T helper, and within the T helper, you have the Th1, you have Th2, and you also have Th17, which, you can also see defects in like IL-17 and some other immunodeficiencies. In terms of the labs, which subset of leukocytes will be high in this disease? And think back to eczema. The eczema is a clue. Which cells are abnormal? Yeah, exactly. So it's the high eosinophils. And I'm giving you IgE because it's part of the name. So hyper-IgE syndrome, of course, it's going to have a high IgE. Okay. Keep this constellation of symptoms in mind as we go through the other immunodeficiencies. I think one of the key strategies for doing well on these exams is to go ahead and see what are the features on demographics, presentation, labs, and other forms of data that help you rule in or rule out a disease. So with that spirit in mind, let's take a look at this vignette. So we have a young child who presents with recurrent infections. Surprise, surprise, it's an immunodeficiency. This is something that's a little bit unique. There's difficulty with balance, and there's an abnormality that's found on brain MRI. I'm not telling you exactly what that abnormality is, but just know there's an abnormal MRI and there's difficulty with balance. And we have the skin findings at right. So it's a little bit zoomed in, but this is a micrograph of the skin, a picture of the skin. And we already have folks jumping in with what they think the diagnosis is. We'll give it a couple seconds to let others put their nickel down on what they think the abnormality is or the diagnosis is. And folks are correct. This is Ataxia telangiectasia. What's nice about some of these diseases is that the name tells you what you're going to find clinically. Ataxia, of course, a gait abnormality. Telangiectasia, which is the skin findings that are shown here on the slide. And that's really the clinical syndrome. I've added a few things. There's an IgA deficiency. Of course, we've got the angiomas. And as folks have already put in the chat, there is a defect in ATM, ataxia telangiectasia mutated. Here's the next level of sort of basic science knowledge. What is the function of this gene? High level. I mean, obviously, we can go into a lot of detail, but sort of what cellular process is ATM involved with? Anybody know? I love it. Folks are getting really, really detailed here. Yeah, it's involved in detecting DNA damage, right? And as you can see in the schema on the right, this is really critical for cell because detecting and then repairing DNA during the course of cellular DNA and then cellular replication is critical for preventing things like cancer, but also recall that lymphocytes in particular, but many immune cells really, one, have very high replication rates if there's an infection, and two, lymphocytes in particular are rearranging their genomes to produce immunoglobulins and T cell receptors. So this is something that affects multiple systems, multiple parts of the body. It's not surprising then that we see problems in the brain, problems in the immune system. The inheritance I already showed on the prior slide. It's an autosomal recessive defect. And what cellular defect is involved in ataxia telangiectasia? I already sort of gave it away. Is it a granulocyte problem or a lymphocyte problem? So typically, you see lymphopenia, so low lymphocytes, low B and T cells, as the predominant finding. And in terms of the labs, you might see a high AFP, which is just a lab test you can send, alpha fetoprotein, and you see low immunoglobulins. All of this ties together because if you have lymphopenia, you have low B cells, and then you also have low T cells. And the T cells are important because they really help with class switching, for instance. So T and B cells have very interrelated functions, and you have defects in immunoglobulin production. Okay. Here we have another vignette. We have a young child who has recurrent bacterial infections, and there's a unique constellation of additional findings. And just as another tip here, notice that while the pattern of infections is very important, is it mostly bacterial infections? Is it mostly viral infections? Is it all infections? While that's very useful, even more useful is the presence or absence of some of these extra immune symptoms. So for instance, with Ataxia telangiectasia, it was the presence of Ataxia, as the name implies, that really clues you into the diagnosis. Here you have albinism. So we haven't heard about albinism before. We also have neuropathy. So there's a nerve and there's a cutaneous component here. And notice that this is in a peripheral blood smear. This is in a bone marrow biopsy. And we're seeing some very strange granulations in these immune cells. And folks are just all over this because this is such a unique combination of symptoms. This is Chediak-Higashi syndrome. Beautiful. So the last slide gave you the clinical presentation. Other words you might hear in the vignette is a lymphohistiocytosis. And the specific bacterial infections they might mention recurrent staph or recurrent strep infections. Notice they're both gram-positives. The gene, as already pointed out in the chat, is LIST. What does LIST do? Yeah, so it has to do with transport, and specifically it's lysosomal trafficking. The way I remember this is look at all those granules. Remember that lysosomes are these sort of bags, I think of almost in the cell that carry things around. They're involved in sometimes carrying toxic enzymes and a toxic environment that helps killing microbes. And as pointed out in the chat, you need microtubules to shuttle these things around. And so, of course, it makes sense that microtubules, if they were dysfunctional, might impact lysosomal trafficking. Here's the cool thing. If you remember that microtubules are involved and that there is a lysosomal defect, it helps you remember the rest of the clinical presentations, right? So let me explain. If I have trouble with the microtubular cytoskeleton in a cell, that means that long cells, right, that need to move things within the cell up a longer sort of distance, as well as cells and tissues that need to sort of transport things from cell to cell, they might be affected. So think about it. If you have nerves are very long. You need to be able to maintain good communication between the distal axons and the cell body. So it makes sense that you would have neuropathy and neuron issues. Similarly, melanocytes, which, as the name suggests, are involved in melanin production and pigmentation, they need to pass off the melanin throughout the skin. And if you have a defect in microtubules, you can imagine how that would be defective. So that's just it's a memory trick to remember the constellation of symptoms that come from Chediak-Higashi syndrome. All right, the inheritance, y'all in the chat have already put it in, autosomal recessive. And here we have a number of labs that are abnormal. Folks have already put some of it in the chat. In addition to the lymphopenia, you can also see coagulation defects. And at right, what I'm showing are the giant granules. And I'm just going to highlight that right here. So here, the giant granules, you see some giant granules in the cell here as well. It's an abnormal looking bone marrow aspirate. All right, here we have another one of those feared cytology, or not cytology, flow cytometry images in the vignette. And I've sort of stacked this. No one patient, well, I will never say never, but it would be unusual to have one patient that has all of these microorganisms, but there's something that all of these microorganisms share that I wanted to highlight. So you have a young child with Nocardia, Pseudomonas, Listeria, E. coli, Serratia, Candida, Aspergillus. I'm overloading you here. This is not how the vignette would actually look. And you have the lab result at right, where, again, you have the control on top, and you have the patient. And you notice that the control, when stimulated, stains positive for rhodamine, whereas the control, the patient will not. And there's sort of an intermediate phenotype with the mother of the patient. Y'all are too good. These are all catalase positive organisms. And there's a mistake on the slide. It's not Chediak-Higashi. You all are absolutely correct. It is chronic granulomatous disease. What gene? You guys already put it in the chat. It's NADPH oxidase. The function of the gene is to do what? What does NADPH oxidase do? What's the function of that gene? Yeah, it's expressed in phagocytes. Oxidative burst. It creates superoxide, right? And superoxide is toxic to cells, particularly microbes that are catalase positive, right? So the inheritance, X-linked recessive. And this is what you'll see classically in first aid, where you have a failure to reduce nitroblue tetrazolium dye. In the newer test, which is what I'm showing here, is either a rhodamine or dihydrorhodamine flow cytometry. If you were really being technical, you would see decreased green fluorescence. In this case, it's a plot, so the color doesn't mean anything. The red doesn't imply the actual color, it's just the graphic. But it would be an abnormal dihydrorhodamine flow cytometry test. Perfect. We're getting really close to the end of our session here. There are a number of other immunodeficiencies that I wanted to highlight. And some of these don't have a great graphic to go along with them, so I just wanted to create a table for you all to see and fill out together. So CVID stands for common variable immunodeficiency. It tends to affect older individuals as opposed to the couple of month old to a couple of year old patient. These folks can, present slightly later in life, and they're at an increased risk of a couple of non-immune diseases. So in the chat, what are the diseases that are more common in CVID, or conditions that are more common in CVID? What are some of those diseases? Autoimmune, I love it. Yes, absolutely. While folks are thinking lymphomas, absolutely. Lymphoma and autoimmune diseases. While you all are thinking of other associations, recall that this is due to a defect in B-cell differentiation. We actually don't really know the genetics all that well. Sinopulmonary infections, absolutely. And when you have chronic sinopulmonary infections, you can have bronchiectasis, right? So it's exactly as you all said, increased risk of autoimmunity. You have lymphoma, bronchiectasis, and sinopulmonary infections. Perfect. What about IL-12 receptor deficiency? What type of infection, big picture, do these folks tend to have? And it's useful to think about what is the function of IL-12. We recall that it has to do with a particular Th cell. And folks are absolutely correct. It has to do with both mycobacterial and fungal infection. Folks in the chat putting in the very subtype of helper cells that are involved. That's perfect. So mycobacterial and fungal infection. Wonderful. Next, we have chronic mucocutaneous candidiasis. The name really gives this away. I wanted to focus in on the the cytokine that's involved. Obviously, the candida is abnormal, and what I'll also say is that you might hear in the vignette that they have an abnormal response to like candidal antigens if you do a skin test. So what is the cytokine that might be abnormal here? We've actually mentioned it once already in a sort of different context. Yep, Candida is absolutely right. So IL-17, you can have IL-17 defects in chronic mucocutaneous candidiasis. Okay. Next up, we have SCID. I mentioned SCID before, severe combined immunodeficiency. Here's where we're going to get into some of the genetics of SCID. I love it. IL-2 receptor. That's absolutely right. Remember that IL-2 is a T cell stimulatory cytokine, but if you don't have T cells, you're going to end up with B cell defects as well. So that is a pretty common one. There's another gene that's very classic for SCID. And while RAG, absolutely, RAG1 and RAG2, the so-called Omen syndrome. Yep, that's absolutely right. And there's another gene that's involved in nucleotide metabolism that if it's messed up, bingo, I see someone put it in the chat already. So the three that I think of is the IL-2 receptor, as mentioned, the adenosine deaminase, as folks have put in the chat now a couple of times, as well as the RAG genes. Keep in mind that the way these kids will present is a failure to thrive syndrome, the chronic diarrhea. In the chat, someone pulled TREX, right? The T cell receptor excision circles. And so what you'll see is low Tregs because you don't have T cells that are rearranging their genome for the purpose of creating TCRs, and so that'll be low. Remember how I told you that DiGeorge's has an absence of a thymic shadow? You can also see that in SCID. So that's why I mentioned at that point that if you don't see a thymic shadow, it's not like you can automatically go to DiGeorge's because there's a little bit of a differential there. And that's why it's so important to know the differences, right? DiGeorge's, you'll see the conotruncal heart abnormalities, so truncus arteriosus, tetralogy of Fallot, whereas you don't really see that with SCID. Similarly, the calcium issues, if they include that in a vignette, you're thinking more DiGeorge's. And if they're presenting more of like a boy in a bubble picture, then you're thinking more about SCID and the possibility of these different diseases. So that's perfect. The treatment for SCID, this might come up. What's the only curative treatment for SCID? The only way to permanently cure this disease? Yeah, I'm seeing the correct answer in the chat already. So it's a bone marrow transplant. You have to give them a brand new immune system, What's unfortunate about that is, bone marrow transplants can have complications. And the good news is that we may be able to do autologous transplants with genetic therapy for some immunodeficiencies, and work is ongoing there. Awesome. Boy in bubble. Great connection there. Okay, you can also give IVIG, which is just immunoglobulins that are pooled from a bunch of different donors and then given to patients. Okay, next up we have hyper-IgM syndrome. Hyper-IgM. What is the genetic defect of hyper-IgM? Yep, exactly. So if you stop and think about it, if someone has high IgM, in this case, it's probably because there is a defect in class switching. So as I've mentioned a couple of times, T cells are really critical for class switching, and it's the CD40 ligand interaction that is important for that. And you can end up with hyper-IgM syndrome. Excellent. And then last but not least, we have leukocyte adhesion deficiency. What's the genetic defect here? I already see it in the chat. LFA1, CD18. A classic one here is that, remember that if you have a problem with leukocyte adhesion, then you don't develop abscesses, which is very similar, right, to the cold abscesses of Job's disease. So how do you tell them apart? It goes back to what I had mentioned about the associated clinical findings. So with Job's disease or with hyper-IgE syndrome, with cold abscesses, you're also looking at the characteristic facies. You're looking at easy fractures and bone abnormalities, retained teeth. You're looking for the eczema. You're looking for the lab abnormalities that are part of the name, the high IgE. Whereas in leukocyte adhesion deficiency, some of the other things you might see is, and this is classically what you see in first aid, is that there's a delay in separation of the umbilical cord, for instance, right? So all of that can help you in differentiate between the different immunodeficiencies. All right, that was a whirlwind tour of immunodeficiencies. Hopefully that was useful. We focus mostly on the high yield stuff, the most commonly tested things. We can't cover everything in 50 minutes to an hour, but I hope that it will cover the basic science that will come up on your exams. This is our slide where I just wanted to make the point that there's a range of things that we can help you with, that we can partner with you to do better on your examinations. There's a bit of a sale going on, 10% off during the spring study sale. And I'll just point out that there's other things that might be of interest to you, including a 20% off on Cramfighter 6 and 12-month packages. And you can see that in the slide, the promo code. All right. I'll leave this up for a couple of moments. Any questions about immunodeficiencies and how it might be tested? This is your moment. While folks are thinking of any questions, I'll just say that I really appreciate the participation in the chat. This is really so much more enriching when you all are putting your thoughts out there. I appreciate all of that participation. It's a lot of fun to go through this together in a community of folks who are learning about these diseases. And I'm not seeing any questions in the chat, so I'll give it a few more moments. But if we don't, I really wanted to wish you all the very best in whatever exam or the next step is for you on your medical journey. And we really hope that we can be a part of that success, whether it's through a webinar or in any other way. All right, everyone. Signing off.